Well, good morning. Welcome to Improving Incident Patient AVF and Place Rates Kickoff. The network has goals set for incident patients, and you can see where the red arrow is, the percent patients with AV fistulas. From our March 11 fistula first dashboard, we're at 41.5% of our incident patients start dialysis with an access with a fistula in place. So for you, we're looking in place rates. For others, for the prevalent group, we look for in-use rates. So we're looking for rates that are greater than or equal to 60%. And the U.S. As a whole only has 35.1%. So, and you can see for our percent prevalent patients with AVF, the national rate as of March 2011 was 58%, and we were at 66.3%. And because of reaching the national official first goal, CMS has set our new prevalent rate at 67.3%, so our medical review board went and increased our network goal for 2011-2012 to greater than or equal to 68%. So one of the areas that we thought we could have a big impact in would be getting the increase in the incident patients with AVF place, because those will eventually mature and they will become our prevalent patients with AV fistulas. So we can actually, this would be a two-prong win for us. And then, of course, with our percent prevalent patients with catheters greater than 90 days or more, the CMS, the KDOKI, and the network goal is to have less than 10% of our patients with catheters or with long-term catheters with no other access in place. So when we talk about the project goal for this particular project, this is being done with your organization solely in the state of Idaho. And when we looked at the data from the Fistula First data, you have the highest percentage of new patients coming into your facilities. And so we thought this would be a wonderful opportunity not only to help with the overall fistula rates in the state, but within your organization. But we have a unique opportunity because you have a large percentage of new patients coming in, that if we can move your numbers and improve your access placement before patients even start dialysis, that will be a win-win situation for your organization. So that's where the information came from. It came from the Fistula First dashboard. And for incident patients, because the numbers overall are very small compared to the patients who are on dialysis now, we look over the last year worth of data as opposed to looking over maybe 6 months worth of data or the month before, that sort of thing. So we look at the entire prior year. So we have a WebEx kickoff, which is what we're doing today. And then at the end of the week, we're going to be having an educational WebEx. And we're going to try to give you some tools and some ways that while you may not be able to impact the patients that are in stage 4, you say, well, you know, they just show up in our facility. We're going to show you and give you some ideas on how you can, if they do just show up with catheter only, what you can do in your facility to get that process moving forward quicker than normal. So that's what the educational WebEx is going to be about. And then there is a worksheet, and we'll go over the worksheet in a couple of slides here, that you're going to be reporting your new patients to me on a monthly basis. And we're actually going to track all of the new patients from the start of the project, and we're going to keep them on the worksheets through the 6 months, because we want to see whether or not, once you do get those patients and get their accesses, their fistulas in place, we want to see if they actually get used within the 6-month time frame. So we're going to track them all from the time that they come in as a new patient until we end the project. The project will end with February data collection, which will be to meet in March. So by mid-March, you'll be done with this particular project. In November, we'll be issuing an impact query. Now, that is to tell us how we are doing as a network in providing you support, technical assistance, the resources that you need, whether or not you find these WebExes helpful for you in your planning of your action plans, tracking your patients. So that's what that impact query, we actually write a report and we send that to CMS because we get graded by CMS on an annual basis. You get to see them once every 3 to 4 years. We get to see them every year. So, and we have to show them how we did on this project. And basically the information that you give us for that particular query is how we alter our projects for the next group of individuals, facilities that participate. So the ultimate goal of the project then is to increase the aggregate. Now aggregate is, we're going to look at all 8 of your facilities. We're not just going to look at Facility 1, Facility 2, or Facility 3. We're going to look at all of them together as a group. And what we want to do is we want to increase the aggregate incident patient AVF in place rate. In other words, we don't want them just coming in with a catheter in place. We want them coming in with a catheter or a graft with a fistula maturing. That's what we're looking for. Something is to have the fistula maturing at the intervention facilities. And we want to get that to 22%, and that's a 2 percentage point increase. What we found is that we have now 30 facilities that have greater than 60% incident patients coming in with a fistula in place. And so it's been going up about 2% per year. So we're going to see if we can't, within your group, get that rate to go up by 2 percentage points. So that's what the ultimate goal of the project is going to be. Now, how are we going to do this? Well, we need to use a root cause analysis, and we sent you an environmental scan to ask you what you're currently doing and what you think the barriers are, and why you can't, why your patients aren't coming in with fistulas in place. And this will help me design things to help you make it happen. And we have a unique opportunity that we'll be talking about in just a few minutes that hopefully will help get everybody communicating. But you'll have the environmental scan that we ask you to return back to us. And, there are lots of different tools that you can use to do root cause analysis. I find that fishbone diagrams are pretty much the easiest ones to use. I'm going to send you an electronic one, and I also want to send you the slides. I'll send you these slides when I'm done so that you have them to review with your QI team. And then there's going to be an action plan that you'll need to return to me. It's 2 documents, actually. It's a Network to API document, and you should have received that already. And we'll go over that in just a minute. And then there's the action plan that goes along with it. And then as far as the monthly measurement tool, there's an incident AVF worksheet. And that's going to help assess the progress on whether or not, number one, we are having accesses that are maturing and in place, and number 2, whether or not they're progressing to be actually used fistulas. And of course, the definition of a mature fistula is getting 2 needles in at the ordered blood pump speed without having an infiltration. So we're hoping to see some of those in the 6-month time frame go from being in place to in use for you so that it will increase your fistula rate. And then, of course, if it's not happening, then we need to adjust your action plan because you're probably not measuring or looking at the right steps in order to move this forward. This is the fishbone diagram that I'll be sending to you, and you can see up in the corner here that this is highlighted. Well, that means that you can just click on it and you can type in whatever category that you want. Now, we use a fishbone diagram as category across the top and the bottom, and then there's causes under each category, and then the effect is that you don't have enough or you don't have any fistulas in place, that you might just have catheters coming in with no other access in place. And so what are we going to look at? Well, one category might be surgeons, for instance, that the surgeons aren't placing them. It could be, another category would be the patient. Maybe there's an insurance issue that goes under patient. Maybe the patient refuses. and they just want to have a catheter. We know that patients kind of fall in love with those catheters, so the longer they stay in, the more they think that it's a good thing to keep, especially people who are needle phobes. And I know I'm a needle phobe. I know that if I had to choose, I really wouldn't want to be stuck all the time, but I also know that it's not the gold standard either, and so I'm going to do things in my power to make sure that I get a fistula if I need one, even though I'm a needle phobe. And that would be I'm going to learn to self-cannulate, and I'm going to use the buttonhole technique. So, and we need to get people to think about those kinds of alternatives in order to we don't want them to settle for the one that's going to have the most complications and that could impact the longevity of their life. So once you get all those categories and then you fill in the causes or the problems under each one of those categories, a lot of times it jumps right out at you what the problem is. So I'm going to send this to you. You can use it if you want. It's not for you to send back to me. This is for you to keep internally for your QI committee. If you want to use it, fine. If you find that it's too complicated to use and you've got another one that works better, then that's good too. The Institute for Healthcare Improvement, IHI, has a lot of different tools that you can use to do your root cause analysis. So that's just one example. Now this is the spreadsheet that we're going to be using, and it's called the Incident Patient Vascular Access Tracking Tool. Now, where there is red here, it needs to be filled in. So we want you to put your facility name in here, and the person who is in charge or the person who's filling out this form, because if I have questions then I know who to call and who to ask for. And then your provider number, that is your 6-digit Medicare number. In Idaho, it's a 132 number, and so if you know what that 6-digit number is, please put that there, and then put your phone number where I can contact you. What you will change every time is you'll do a file save as, and then what you'll do is you'll change this date. So our first reporting date will be, I want September data. And the data is usually collected, our official first data is usually collected on the last day of the month. So you have to wait till the last day of the month before you can go back and tell me who your incident patients are for that month. So you'll put their names there, and then what access type they have. I want to know who the nephrologist is. I want to know who the surgeon is. If they did come in with a fistula in place, put the date that it was put there. Whether or not they had any previous access education. And if you know you did it, then it's a yes. If you're not sure, you can ask the patient, were you told about the different vascular access types? And then was there vessel mapping prior to this access creation? Of course, if they don't have a fistula then, and they just have a catheter, they may have had mapping done, but maybe not. So you need to ask that question. And what happens is the date that you put here for a fistula placement will automatically populate 6 weeks or 42 days after this date. So this is the kind of ballpark date that you're looking at that your fistula should be mature by then. Then this is for the actual first date of use. And the reason if the catheter only access, say, and it's a drop-down box so you can pick. So this one is, in particular, says the patient wasn't a candidate. So the surgeon obviously couldn't find any veins that were suitable for that. It could be the patient refused is also there. So all you do is click on some of these. These are all drop-down boxes here where you can put your information in. Now you'll have to type in your nephrologist and your surgeon and your date of placement. And then the action to be taken. What are we going to do to get something other than just a catheter in that patient? For instance, this one is a scheduled vessel mapping. So if that patient comes in, doesn't have any kind of a plan, the thing that you could do is you could get something scheduled for them for their placement. And if those patients don't have insurance right now, one of the things that you want to take a look at is, they'll be there 3 months before they're Medicare eligible. Well, we can have that scheduled on the time that their eligibility becomes active. And that way we don't wait until they are Medicare eligible. We schedule their
Pre-dialysis, may help you.
And that way we'll have them all ready to go by then to get their mapping done. And then we can get their surgery scheduled for them shortly after that. Because sometimes you have to wait several months, depending on how busy your surgeons are, to get the patients in there. So if we can work ahead of time and get some dates in place and make sure that we're working diligently to get that patient, on the active insurance rolls, if that's what's holding them back. If insurance isn't holding them back, then we can get them scheduled right away. So those are the kinds of things that you can put in your action plan on what you're going to be doing. So every time you get your new patients for the month, we want you to keep the ones that you've had in September, and then we want you to add any new ones after that. So nobody will ever fall off, and we'll just keep tracking them the whole time. Now, let's look what the conditions for coverage say about quality assessment and performance improvement, your QAPI. It says that the dialysis facility must develop, implement, maintain, and evaluate an effective, data-driven QAPI program with participation of the members of the interdisciplinary team. Well, who's the interdisciplinary team? Well, whoever interacts with your patients is the interdisciplinary team. So we've got your surgeons, we've got your nephrologists, your medical directors in charge of your whole facility. We've got the nurse manager. We've got the nurse that's taking care of the patient. We've got technicians. So we've got social workers. We've got dietitians, because they're all going to have interacting and impacting. One of the things that we've got planned is that on October 28th, and I'm not sure if you got your invitation yet, if they've been sent out yet, but they'll be sent out from the surgeons group in Boise. But we're going to have a live one-day conference over in Boise at St. Luke's Medical Center in Boise. And Dr. Vo Nguyen and Dr. Mike Millay, who are both nephrologists, and myself are going to be holding a day-long conference for the interdisciplinary team. So we've been invited by a vascular surgeon in Boise to come and do this presentation. So we'll have interventionists, nephrologists, surgeons. We'll have the dialysis staff, the nurses and technicians are welcome to come, and we're going to ask the discharge planners, hospitalists, and anyone who's involved with our patients who may be there right before they come to dialysis and then when you do get to dialysis. So we want that whole team together. So it should be a good day. They've applied for CEs for this program for the nurses and the technicians, and for CMEs for the docs. So when you have an opportunity to talk to your doctors, let them know that October 28th is the date. It's a Friday, and I think we'll start around 8 o'clock and we'll be done about 4. So that's something that's going to help drive this process for you. So if you want to have an opportunity to talk with surgeons and interventionists, this would be a perfect opportunity to be able to interact with them, especially at lunchtime. Lunchtime is a free time to sit at tables with them and to interact with them. So it also says, your conditions for coverage say, it must focus on indicators related to improved health outcomes and the prevention and reduction of medical errors. So we're focusing on improved health outcomes because we know the highest morbidity and mortality happens to be with patients who have catheters as their choice of vascular access. And so we want to target those folks and try to get them the gold standard. If they have the vasculature to support a fistula, they should have a fistula. So let's look at the forms that are required to be turned in. Now, these forms only come to me one time, so you just need to sit down and brainstorm and get them completed. So it asks let's look at the Network 16 QAPI form first. It asks for the facility name and your 6-digit provider number and the date, and then you want to set your goal. And, if you don't think you can get a 2% improvement, set it for what you think you can reasonably expect in your facility based on your barriers that you have. If your barrier is a surgeon and there's no other surgeon in town and it's hours and hours to the next surgeon and patients can't get there, then, you're going to have a hard time moving your outcomes to be 2%. So you need to think about that, and that you do after you do your root cause analysis. And then your opportunity for improvement. What's the problem statement? To achieve, maintain, or exceed that performance target that you've listed there. And then you put down what is your facility's percent of patients achieving the outcome. So how many patients now do you have? How many new patients do you have, that have officials in place? And then you've got a problem identification list. So what is it? List some of those problems of why your patients are coming in with catheter only, for instance. And then maybe you're already doing stuff. Maybe you already have a plan, and you already have activities that you're doing to try to get that. Maybe you've already talked with your medical director, who's talked with your surgeon, or you've had conversation with the other nephrologist. If you've got a nephrologist who just loves catheters, you need to get your medical director involved, because your medical director is ultimately responsible for the outcomes of your facility. And so, that medical director should have conversation with those physicians who think that, catheters are the way to go for new patients. I know a lot of you say, well, they end up in the hospital and then they end up on dialysis. Yes, they do, but that's not the majority of our new patients. The majority of our new patients have been seen by a nephrologist for over 12 months, and they still come into a dialysis unit with a catheter only. And there's something wrong in the process there, if that's the case. I understand when somebody is emergent in the hospital. Boom, they have an event, they go into renal failure, they need dialysis now. I understand that, but that is not the majority of our patients. So we shouldn't be seeing all of them coming in, starting with catheters. Not if they've been seen for a long period of time by a nephrologist. They should have already had plans in place and something in motion. And so we need to have that communication about why that's not happening in your area. And then the simple question, are you using a protocol for management? Do you perform chart audits? Yes or no? If you're not, that's okay. Don't say you're doing it. But if you are doing audits, how often are you doing them? Because audits are a good way to see whether or not people are following policies and procedures, whether or not patients are falling through the cracks. Somebody just, never followed up on that issue, or things like that. So you might be able to find those out from chart audits. But the big question is if you're auditing and you find that people are following protocols, but you're still getting patients coming in with high catheter rates, then we've got to ask our question, are we actually auditing and looking at the right things to get a change in practice? We have to change culture, and it's not easy to change culture, and that is the culture of your area. This is the way we've always done it. Well, is it the best way that you should be doing it is the question you should be asking, not just say, well, this is the way we've always done it, so we're going to keep doing it. If it's not broke, don't fix it. Well, quality improvement says even if it's not broken, we might be able to find a better, more effective way to do things. And wouldn't your life be easier if everybody came in with mature fistulas ready to use, as opposed to having, all new patients come in with catheters and having the issues with catheters clotting and infections and patients not in their chairs because they're in the hospital dealing with infections? That's what quality improvement and continuous quality improvement is all about. It's about trying to find better ways to do things or improve your processes. So then once you get this page filled out, all of the stuff on the top here you've already answered in this sheet. So you just transfer the information over. And then based on your root causes, based on what barriers. Now there are some barriers that are called exogenous barriers. Those barriers are barriers that you might not be able to change. If a patient doesn't have insurance and surgeons aren't going to put in accesses without, for free, then that is a barrier that you're probably not going to be able to overcome until we can get that patient some way of getting their access paid for. So that's what an exogenous barrier is. But, even if a patient absolutely refuses, we need to continually provide them education about the benefits of having a different access type, to try to get them to even think about or consider changing their mind. They may not go for, I absolutely refuse to, oh yes, I want a fistula. But it may be that you've told them about the risks of having a catheter and all of the problems associated with that. Then they might just start thinking, wow, I don't want hospitalizations all the time. I don't want, I don't want clotting, and I don't want them to have to put in another catheter. And so we move them baby steps at a time. But the process is to try to get them to those absolute refusals, to at least think about it, to maybe talking with a patient who had a catheter and had those bad experiences, who now has a fistula, to tell them that, well, I just got sick of it, and then move them along that continuum until they decide that maybe they should look into a different access type. So you're going to put your steps on how you're going to move. Now, we're doing a rapid cycle improvement process. And the reason I say that is because some things might take 6 months to a year to change. But we've only got 6 months for this project. So rapid cycle improvement means we need to find things that we can change in the process quickly over 3 to 6 months to at least get us to move in a positive direction towards that 2 percentage point increase. So we have to think in terms of that. You also plan for the future, but what is it that we can do right now that we can change and have some positive results from that? And so here you'll list the steps that you're going to do. Say you're going to do some education, plan some education. Who is going to do that? Who's going to be responsible for doing this particular step? And what date are you going to start this? And when do you think it'll all be done by? So you're going to kind of guesstimate when you think how long if you're going to educate your entire staff, how long is it going to take you to do that? Probably longer than 1 day. It might take a week because of the different shifts and the times that people are available and your staffing mix, how you're going to do that. And then a checkpoint date. So if you set an estimated completion date for a week from now, you might want to check in about 4 days to see how you're doing. Do you have the majority of your staff already taken care of? And, are you going to get to this completed date? Because if you wait till the completion date and then you go, well, we didn't get there, well, you could have rescheduled something at your checkpoint knowing you're not going to get it. You could have put it a few more days out. Because we can't let this completion date drag on and on and on, or we'll never get it done. And then there's a place for comments. For instance, we know winter's coming. We know flu season is right around the corner. What happens if we get a lot of call-offs for the flu? And you had something planned that you were going to do with the staff, and then the flu bug hit, and you couldn't do it. Because we have to make sure we get patient care done before we do anything. So, you put there that we had to change things due to that. Or you had a company, like you did, you had a company event scheduled that you had to go to, and you weren't available to do this kickoff when we originally had it scheduled. So we had to make a change, and we had to pick a new date and get it all scheduled and everything. And we got that completed. So that's how you fill out this as you go along. Now, you'll put your steps down. Of course, the right side of this will be blank, unless you've already got things in the works. If you've already got things moving, then you should have some completion dates over here. But if you've got some new steps that you're adding, there won't be a lot over here yet. But again, we have to make sure that it's completed by the 6-month time period. And then once you get this all completed, then you're going to fax these forms back to me. Everything that comes back to the network needs to be faxed. If it gets emailed and it has personal information from patients, then it's a violation of HIPAA, and I have to turn that over to my security people, and they have to tell CNS about it, and we don't want that to happen. So everything needs to be faxed. Now, as far as how you're going to do this project's going to be incorporated into your QAPI process, and it needs to be reported in your QI minutes. And so since we're doing this on a monthly basis, you should have a QI meeting once a month, And then you need to update how your progress is on your reports. And you may have a month go by where you don't have new patients. You'll still send me a report, and that report will be blank. And then your cover sheet, you can put no new patients. And then that way we know. But you still want to have plans in place when you do have patients come in. And so, for instance, if you have no new patients and you're starting off in September with no new patients, then in your QI minutes, you just want to say that you started this project, you submitted your action plan, that this is what we've got scheduled before your next meeting. We're going to do this and this and this. And then, of course, when the next month comes along, even if you don't have any new patients for that month, you're going to report on any processes or any training that you might have done with your staff. And then you make sure that your documentation is available in case you get surveyed. They know that you're going to be surveyed. What we have done, we have quarterly calls with the state survey agencies. We encourage them to let us know when they're going to be doing surveys in their states. We've created a document, and that document has a section for data and a section for QI. And in the data, it asks if you're current with your data reporting that you're doing for them, if you're reporting on time, or if you have to be contacted because you're late, or if you're not turning in materials because you have to be participating in network activities, so you have to be sending those forms in. Same with the QI department. It asks what the official goals are, what the catheter goals are for the network, and then it asks what your current rate is, and so I put that in there. It also asks if you're participating in a QI project with us. If you are, I put that there. And then it asks if you turn your forms in on time, if I have to contact you, or if you're not participating. And then we fax that to the survey offices so that when they go in and do your surveys, for instance, that they have that information. So don't be surprised if they ask to see your QI project that you're working on. Now, one of the other things that we want to make sure that you're aware of is that there is a quality incentive program out there, and they're adding different things. And currently now, starting in 2012, you're graded on what your adequacy scores are, what your suboptimal hemoglobins are, and what your hemoglobins greater than 12 are. And you've already been told whether or not you're going to get your full reimbursement for next year through this quality incentive program. Well, they're already looking at 2013 and 2014, and they collect that information 2 years before that. And so they looked at your 2010 data, and that's how they determined whether or not you're going to get, reimbursed. So we need to make sure that we're looking forward in that respect to make sure that if they do make it a proposed element for this, we want to help you make sure that you get your full reimbursement. We are here to help you if you get surveyed and you don't have a positive survey. You call the network and we can help you work on those areas that you were cited in. That's my job, my responsibility. So we need to make sure that if they decide to make this an element for the quality incentive program, that we're getting you in place to get full reimbursement for those things. So how can we help facilities? Well, I'm going to review your action plans that you send in. And if your action plans don't look like you're moving in the right direction, then I can call and I can make some suggestions that you might have better results with on your action plan. I'm going to look at your monthly worksheets, and we're going to make sure that you're working, that you're getting positive outcomes, so that if you, for instance, your accesses aren't maturing, then, perhaps we can have conversation with the surgeons. We can make sure that the staff knows about how to assess for maturity and how to do it in a more time-efficient manner, that we're going to do it sooner rather than later to make sure that those accesses mature for you so that you're not frustrated and that and the patients aren't frustrated, and that they get to use those fistulas that were created. I can assist you in revising your QAPI process to throughout that whole 6-month period, but I'm available to you all year long. All you have to do is call me on the phone and say, I need some help. And I'm there to help and offer whatever assistance I can. Remember that 2011 impact assessment? This helps everybody in the long run because it allows me to design better projects and better tools for you to meet the goals. And then, of course, remember the remeasure is going to be, your last one you fill out will be at the end of February, and you'll submit that to me in March. And so that's when I'm going to get that information. And that will be the end of the project for you. And then provide technical assistance throughout the entire project. And again, that's any kinds of tools and resources. Also, your corporate QI person has also been invited to listen in, and she's getting all the same information that you're getting. So she can help you as well as myself, help you through this project. So again, this is our special project presentation that we're doing. Again, it's a day-long interdisciplinary program, and we've got everybody from the dialysis side plus people, everyone that we could think of from the hospital side that you might interact with or who will interact with our patients when they're hospitalized. The speakers are Dr. Vona Wynn. He's our champion nephrologist in our network from Olympia, Washington. Dr. Mike Millay, he's a nephrologist from Boise. Myself, and we'll all be over there for that October 28th CE program. And it'll be really nice, and we'll be able to have lunch. And we did this with Back to the Basics. We did this with Forward to the Future. And if you didn't have an opportunity to participate in any one of those that we put on in the last 8 years, it's a good opportunity to sit down and have a conversation with a surgeon over lunch. And like I said, one of the surgeons is the one that invited us to come over and to do this program. So we said this is wonderful because this will fit right in with this project that we want to do in Idaho. So we've got, you'll be tracking all of your incident patients for the 6 months. And remember, a failed fistula is considered a fistula you can't use after 3 months. And so if you're having problems with AV fistula maturity, there will be a program on October 13th from 9 to 10 Pacific time that's assessing AVF maturity. You're welcome to listen in on any or all of our educational programs that we have going on this year. They'll also be posted to the internet afterwards, and so you'll be able to go to our website and you'll be able to view them then. But the one that's mandatory for your project is going to be Friday, October the 7th, from 8 to 9 Pacific time in the morning, and it's strategies to increase patients' AVF in place rates. So we will have strategies for you. We've got some toolkits for you, electronic toolkits and things. So we will, in that particular one, give you some specifics about how you could go about interacting with those folks. And then again, if you can come to Boise on the 28th, that would be great. So the next step, you need to complete your root cause analysis, and you need to get that faxed over. And that is that NW16 QAPI form, and then your action plan. And that's due to me by October the 19th. So I need those 2 forms by then. I need your, also the query that we sent to you, that needs to be sent in by October the 19th as well. But there's a deadline on that sheet. It probably says the 7th of October. And then send your September worksheet by October 15th, and your October one will be due by November 15th. So it's the 15th of the following month that we need you to do that incident patient worksheet. Okay, subsequent worksheets due by the 15th of the following month. And then you can call me for any questions or issues that you might have if things don't make sense to you. I know it's early on a Monday morning. When I get done with this program, I will send you these slides so that you'll have them. and then you'll see all the forms, and then you should have already gotten them electronically. If for some reason you didn't get them electronically, they were sent to nurse managers, so if you didn't get them, send me an email, and I can certainly send them out again to you. And then there's going to be a short survey that pops up if you could answer those questions for me, and we can open this up for questions now. All right, then we'll talk again on October the 7th. I'll see you then. Thank you for joining.